Hello and welcome. Today, we're going to dive deep into spinal implant infections, or SII. Now, this isn't just any post-op complication. It's a really severe one that demands a sharp understanding of how to diagnose, manage, and hopefully prevent it. We're going to walk through a concise, high-level explainer on this very challenging clinical problem. All right, here's our game plan. We'll start with what exactly these infections are, then move into diagnosis and identifying the culprit pathogen. After that, we'll cover treatment, prevention, and the major risks. And we'll wrap up with a quick case challenge to put it all together. So, first up, what are we talking about here? A spinal implant infection is a massive hurdle in postoperative care. You might suspect something if you see a superficial wound infection within 6 weeks or so of surgery, but honestly, the full picture can be way more subtle and tricky than that. Think of it like this. These infections come in two very different flavors, and it all depends on the bug. On one hand, you have the acute infection. This is the loud, obvious one, usually caused by a really aggressive pathogen like Staphylococcus aureus. It screams for attention with fever, pain, the wound splitting open. But then you've got the chronic infection. This one's a quiet, sneaky beast. It's often from a low-key organism, and it can just simmer for ages with maybe some persistent pain and inflammatory markers that are just a little bit off.
So because the signs can be so different, a gut feeling or clinical suspicion just isn't enough. You can't guess. The only way to really manage this properly is to get a precise microbiological ID. That is the absolute cornerstone of the whole diagnostic process. To get a definitive slam-dunk diagnosis, you need to check at least one of these 3 boxes. First, the obvious stuff. You see a fistula, pus, or the wound is falling apart. Second, you get a positive blood culture and there's no other good explanation for it besides the infected wound. Or third, and this is key, you get microbiological proof from multiple deep samples taken during surgery. And let me be crystal clear, superficial swabs are worthless here. We're talking 5 to 6 deep tissue samples to have a real shot at finding the pathogen. Now, here's a really cool technique to boost our chances of finding the bug, especially when we can get the hardware out. It's called sonication. Think of it like a high-tech ultrasonic cleaner for the implant. It blasts the hardware with sound waves, which literally shakes the bacteria loose from their protective biofilm shield. This releases them into the fluid so we can culture them. It's a game changer for unmasking the culprit when tissue cultures might come up empty.
So who are the usual suspects? Well, take a look at this chart. The microbial landscape is pretty predictable. It is overwhelmingly a staph-related problem. Coagulase-negative staphylococci are the biggest players, especially in those chronic, low-grade infections. And right behind them is their more notorious cousin, Staphylococcus aureus. Knowing this is absolutely fundamental for picking our first-line antibiotics before we have all the data back. Which brings us perfectly to our treatment strategy. To effectively manage a spinal implant infection, you need a powerful 1-2 punch. Aggressive surgical cleaning or debridement paired with a long and targeted course of antimicrobial therapy. Okay, let's talk about a common scenario. An acute infection where we try to save the implant. This is called DARE. That's debridement, antibiotics, and implant retention. After the surgery, this is your go-to empirical antibiotic cocktail. You've got continuous IV flucloxacillin as your main staph killer. Then, you add a single dose of gentamicin to cover your bases for gram-negatives, but only if the initial stain isn't clearly showing gram-positives. And finally, you add a short course of oral rifampicin. That's our special agent that can actually get inside the bacterial biofilm. All right, before we dive into how long this all takes, a quick break. I heard this the other day. Why did the bacterium break up with the antibiotic? Because they just couldn't find any common ground for a resistant relationship. Okay, back to the serious stuff. So, a huge decision point is when to switch the patient from an IV drip to oral pills. We don't just guess. There's a strict checklist. The patient has to be clearly getting better, their inflammatory markers need to be coming down, and of course, they have to be able to take oral meds. Plus, you need a good oral option with solid bioavailability. If all those boxes are ticked, you can think about making the switch, usually after about a week or 2. And this kicks off the oral phase of what is often a 3-month-long marathon of treatment. Given how brutal these infections are to treat, it's pretty obvious that the best case scenario is to prevent them from ever happening. So now we're going to shift gears and talk about the strategies we need to minimize that risk in the first place. And look, this isn't a one-person job. Effective prevention has to be a system-wide effort. It means having mandatory meetings with a whole team of experts for complex cases. It means standardizing your antibiotic prophylaxis, like giving IV cefazolin before the first cut. It means everyone, and I mean everyone, adheres to strict infection control. And finally, you need clear communication lines for reporting and handling potential outbreaks. But even with the absolute best prevention, infections can still happen. And when they do, we need to understand just how serious the fallout can be, because the potential for significant morbidity and even mortality is very real. The real danger is when the infection breaks containment. If Staphylococcus aureus escapes into the bloodstream, it's like a spark that can start fires all over the body. This can lead to absolutely devastating complications, like osteomyelitis, that's an infection in the bone itself, spondylotisitis, an infection of the disc space, or even far-flung problems like meningoencephalitis. But the one we fear most is bacterial endocarditis, an infection of the heart valves. And why do we fear it so much? Look at this number. When one of these spinal infections spreads and causes bacterial endocarditis, the mortality rate can be as high as 5%. That is a staggering and sobering statistic. It's exactly why aggressive early management is so absolutely critical. Okay, we have covered a ton of ground. So, to make sure the most important concepts really stick, let's test that knowledge with a quick clinical challenge. Ready? First question, let's go back to basics. What are those 3 key criteria, any one of which can give you a definitive, slam-dunk diagnosis of an SII? And the answer is C. That's right. It's either that obvious clinical evidence like pus or a fistula, a positive blood culture that you can't blame on anything else, or getting multiple identical pathogens from those deep operative cultures. Those are your diagnostic pillars. All right, next up, let's talk treatment. You're dealing with an acute infection, you've done the DIR procedure, but the Gram-Stain results aren't back from the lab yet. What's your go-to empirical antibiotic combination? The correct answer is B. It's that standard DIR protocol we talked about. The flucloxacillin, the just-in-case dose of gentamicin, and that short course of biofilm-busting rifampicin. It's designed to cover all the most likely culprits while you're waiting for definitive data. And for our final question, let's tackle a more nuanced scenario. When we decide to put a patient on long-term suppressive antibiotic therapy, what is our primary goal? What are we really trying to do? The answer here is B, and this is a critical distinction to make. Suppressive therapy is a strategy for control, not for a cure. In these chronic cases where the hardware can't be removed, the goal is to prevent flare-ups. We're managing a chronic, smoldering fire that can't be put out completely. We're aiming for control, not eradication.